Alrighty, thanks guys. Can you hear me all right up the back? All right, good, excellent. For those of you who don't know me, I'm Ryan. I'm one of the third years. I'm very open to anything. If you've got any questions about anything that comes up today, or any questions about the exams, or anything about third year particularly, I don't know if you guys know yet, but if you're going to Eastern Health next year, come and chat to me. So yeah, there's my email, or you can just message me on Facebook or whatever you want, no worries. So today I want to I understand we're at this stage of the year where we're already thinking about end of year exams. At this stage of year, it's all about where's the money at. You know, we can't learn everything. We have to work out what's the most important thing to do with our time. And to be perfectly honest with you, if you spend, where's the time? I want you all to be out of here by 6:45. And I reckon that's all the time you need to spend on lower limb for the next 2 months. All right? So I get to, guys, we'll get through it if we've got to keep getting through. All right, so I could take you through every muscle, every innovation, but that's probably more an elitist academic exercise more than one that's actually going to help you for your exam. So let's just focus on what's important. First thing is don't neglect your OSCEs, okay? So I want to get this done quickly, so if you guys can come down, if you want to come down the front, go through any technique about your MSK or your neuro exams, especially your lower limb neuro, come and see me afterwards, because I think that's the most important thing you need to get out of this, okay? These exams come up time and time again. I know you learnt them last year, but for even us in year 3, they always just chuck an MSK knee in there or something like that. So make sure you know your tests, you know the signs, what's positive, what's negative, etc., etc. If you are going to go and spend your time learning some anatomy, I admire your time management. Well done for fitting it in. Make sure you know more the compartments rather than the individual muscles and nerves themselves. And basically neglect anything in the foot. If you get a question on foot, muscles, or anatomy, I will buy every single person here in HSP, and that's a promise, okay? So, I've got 11, so I have for you today, I've got 11 questions here today. Every one of them is crucially important, which means I want you to take 11 things out of today, and that's all I want to ask from you, okay? So have a look at this one. So this is the first question. This is where you're in trouble if you know me, because I'm going to ask you. Start at the front. It's Daniel, isn't it? Daniel. Good. Yeah, okay. It's C. That's very close. All right. So let's talk our way through dermatomes and myotomes, right? And if there's any questions at the end of that, just raise your hand. But let's talk through it first. So here are the dermatomes. Remembering that there's always a point on your right, there's always a point of least discrimination that you should use in your OSCEs when you're mapping out the dermatomes. And remember to go side to side, right, left, and always comparing back to the person's chin as well. There's always a few grey areas as well, but just the main things to remember are the sole of the foot, S1, medial leg, L4, lateral leg, L5. Moving on to the myotomes. So it's hard to remember all of them, but there's a couple of things you can use to help remember it. So in terms of, I don't know if you guys remember learning about this next year, but in terms of remembering hip flexion, knee extension, and ankle dorsiflexion, they work quite nicely if you think about kicking a football. So if you think about, somewhere, I don't want to go too far away from the mic, but if you just think about L2, L3, L3, L4, and L4, L5 for your dorsiflexion, they work quite nicely in a sequence. So they're the main ones to remember. The other thing is if you can remember the reflex and remember what movement happens when you do the reflex, you can remember the movement and the myotome as well. So knee reflex, L3, L4, ankle reflex S1, S2, and then the Babinski reflex L5, S1, S2. Remembering that the difference between an adult and a child is bringing in a little bit of medicine of the mind here as well. This is good for your VIA as well because they come up. So remember, in a child, the normal reflex is the big toe goes up and the toes are fanned, and that's an abnormal response in an adult. That's an upper motor neuron lesion. Okay, so we're going to start at the hip and work our way down. So here's another question for you. Alrighty, does someone just want to shout it out when you got it? A? I'm hearing some A's. Very good. Excellent. So let's have a look at this picture because I think that sums it up really well. So Trendelenberg's test, remembering it's always the knee it's always the leg that's stable on the ground that is the one affected. So you have your stabilizers, gluteus minimus and gluteus medius, and if you've lost them, you can't keep your pelvis straight. So one side goes up and one side goes down. So the nerve supply for those is the superior gluteal. I know it's a little bit tricky because you'd think superior would go with maximus, but just remember that's one of those cases where it's not what you want it to be. Superior gluteal is your minimus and medius. Inferior gluteal is gluteus maximus. All right, next question, question 3. So I've got 3 x-rays here for you. Hope they come across okay. And order them from most likely to least likely to result in avascular necrosis. Can someone shout it out? It is B. Alrighty, before I lose you guys. Good. We're making good time, but let's get back. Alright. So always remember with these questions, you've got to think, these are all clinical anatomy questions. You've got to think, what is it trying to get at? And then once you get it down to what is the anatomy, what is the anatomical thing I actually have to know to answer this question, they're not too hard. So with this one, I'll go on to the next slide, it'll make it clearer. So for this one, you need to remember your vascular anatomy around the hip joint. So if you see here, you've got your external iliac coming down, coming into the femoral artery once it crosses the inguinal ligament, gives off the deep femoral, and then the deep femoral gives off medial circumflex and lateral circumflex. And this is one of those situations where the branch comes off and then supplies the head of the femur from distal to proximal. So there's another example of that. Does anyone remember the other example of that? Scaphoid, very good. And the anatomy of the anatomy of how this works in the branches here is quite similar to what happens in the upper limb and the shoulder as well. So always making connections there. That'll help you remember it when it comes to the end of the year. So if we come back to this, an intracapsular fracture that's close to the femoral head is more likely to cause avascular necrosis. Number 1 was a trick. They're your epiphyseal growth plates that all kids have. And number 3 is an intertrochanteric fracture between the two trochanters, the greater one on the lateral side and the medial one, the medial trochanter on the medial side. The lesser trochanter on the medial side. That's what I'm trying to say. By far the most common one you're going to see next year when you do your orthopedics is around here, a neck of femur fracture, very, very common among people, especially old ladies with osteoporosis. Okay. another clinical question. You either know it or you don't know it. Alrighty. Righty and Chelsea, you look like you know the answer. All right, guys, bring it back, bring it back. No. F. You're going with F. Very good, good choice. All right, okay. So what's the lesson? Shh. All right, so what's the lesson to take out of this one? What is the mid-inguinal point and what is the midpoint of the inguinal ligament? So the mid-inguinal point is between ASIS and pubic symphysis. Midpoint of the inguinal ligament is ASIS to pubic tubercle, so more lateral. The way I remember these things, I love mnemonics, acronyms, they work for me. Hopefully they work for you as well. So for this one, either remember navel or navy. So going from lateral to medial, you've got your nerve, artery, vein, and then your Y front. Just to remember that the Y, that's medial, and you're going lateral to medial. So once you know that, you can work out the answer to the question. The midpoint of the inguinal ligament is going to be the nerve, and the mid-inguinal point is going to be the artery. Okay, I hope that all makes sense. Sure. Another classic question that you've probably seen a number of times. Shouldn't need too much thinking. All right, so I just want to talk through this. Diagram really quickly. All right. So instead of using tables or words or whatever, I just wanted to talk through this picture to go through everything we're trying to talk about in terms of the hip and the thigh. So if I was going to hang one lower limb picture up on my bedroom wall, this would be the one I would, because it's got everything in there that you need to know. And you remember, it's got things in terms of the compartments and the nerve supply, rather than just the individual muscles, which works so much better because you can visualize this, you can see how it works in space. So if we start from the top, if you're looking at your greater sciatic foramen, there's only one thing you have to worry about going above piriformis, and that's our superior gluteals, which we came across before with Trendelenberg's sign. If you're going for greater sciatic foramen below piriformis, that's where a lot more of the action is. Main one is the sciatic nerve, and if you can remember that that's taking things posteriorly, you think, okay, sciatic nerve, that's going to be innervating the posterior compartment of my thigh. So it's going to be doing knee flexion, hip extension. Right. The other one is the inferior gluteal, as we saw before, with gluteus maximus. And then the pudendal nerve, which you would have come across in your pelvis anatomy, which does that funky thing where it comes from inferior, it goes below piriformis, hooks around the ischial spine, I think it is, and then through the lesser sciatic foramen to do everything in the perineum. Okay? So the obturator canal, more medially, going through the obturator foramen. So I think, okay, medial, so it's going to do the medial compartment of the thigh, which is going to be adduction. And then the last one that's important is between the inguinal ligament and the pelvic bone. Going down the front, it's the most anterior, so I'm thinking, okay, that's going to be the anterior compartment of the thigh. Much as, just to reiterate again, much, much more important for you guys, not just for this year, but for next year as well, because you can't know every single muscle. Just remember what the compartment is and what the innervation is. And if you can remember pictures for that, that's going to help you a lot. And just if you didn't think that anatomy was interesting enough, you would have all read that they discovered a new muscle this year. So the tensor vastus intermedius. So they're not actually quadriceps, they're quadriceps or whatever you want to call it. So there you go. Fun fact for you. I had to fill this, guys, otherwise you'd be out of here in 10 minutes. So anyway, all right, moving on to the knee. All right, so I don't know if this is, I wanted to put this one in here because I'm not sure if you've actually come across it yet, but it's probably the most important thing you're going to come across next year. And it's really easy to chuck into an OSCE or something like that, so you want to make sure you know it. And also it's really easy to remember because all you have to remember is one acronym. So just a little bit of background on osteoarthritis, incredibly common. It's wear and tear on the joint, and it's most commonly occurring at the hip and the knee. So the acronym you need to remember if they give you an x-ray of the knee and they say, please interpret this and tell me what you're looking at, is loss. So you look for the loss of joint space, and commonly that's more commonly seen on the medial aspect of the joint just due to weight bearing than the lateral side. So you can see there you've got the loss of joint space. You also have the presence of osteophytes, which are bony outgrowths. As you can see, there's one there. And then the two S's are subchondral cysts and subchondral sclerosis. So the sclerosis, as you can see there, is sort of that opacity, that thickening and hardening around the joint, and these are all due to the loss of cartilage as you wear down the cartilage with age and activity, etc. So I wanted to put that one in there. It may not come up this year, but definitely remember loss when you get on your orthopedics rotations for next year. Okay, so another very clinical question, because I want to make sure you guys all remember your knee tests. And again, come down the front. If you guys aren't sure how to do these, we can go through them afterwards. I have no problem. All right, I'm putting up the answer. All right. So I'm sure you all remembered that from last year's clinical skills. So that's all pretty straightforward. The main question is, though, valgus and varus, because I always get these confused as well myself. So what's a valgus angle and what's a varus angle? So the way that I remember this is just remember that valgus has an L in it. So you're thinking lateral deviation of the distal bone or joint. So if we take the knee as an example, you can see there up on the right that a valgus angle, a valgus knee deformity is a knock knee deformity, and it's where you have a lateral deviation of the tibias compared to the knee joint. A varus deformity of the knee is what's called bow-leggedness, and that's where you get a medial deviation of the tibias in relation to the knee and the femur. So if we go back to the tests, if you think about the valgus stress test, you're providing a force that's going to put the knee into a knock knee position. So it's going to be testing the stretch of the medial collateral ligament. The other way, the lateral collateral ligament. Okay, I hope that's all cool. All right, Next question, ACL injuries. Alrighty, let's talk quickly about the unhappy triad. Shh. Alright, so the unhappy triad's a tricky one. If that question happens to come up anywhere, the answer's still the classic unhappy triad. So ACL injuries, and this comes into, just for a bit of revision, so this comes into play when you've got a knee that's, so say you've got a leg that's fixed on the ground and you have lateral force or a pivoting injury. That's when you're most likely to tear your ACL. So classically, you've got your ACL, that makes sense because of the twisting. The MCL, that makes sense if you've got a lateral blow because you're putting pressure on the medial side, and the medial meniscus. However, that's where things get a bit tricky because they've done a whole lot of studies, you know, checking what the prevalence of these, you know, the incidence of these things is, and lateral meniscal tears with ACL injury is just as, if not more common than a medial meniscal. So just keep that in mind, that these things that they say are classic or textbook things aren't that textbook in real life. But from a Monash perspective, if this is something that they choose to examine you on, it's still the classic unhappy triad. So yeah, just to reiterate, ACL, MCL, then medial or lateral meniscus. We're going well, guys. Good work. So just while we're on the knee joint, another thing that I wanted to put in as well is, so just remember that if someone's coming in with a sore knee, it could be some sort of infection or inflammation as well. So there's three bursae that you should know about. So the first is the suprapatellar, and that's continuous with the joint space. And that has a lot of clinical applications, that if you say, you know, if someone stabbed you just above your patella, and you've got an infection, that infection can potentially spread to the joint, and you can get a septic arthritis picture. Just remember that. The others have their classic names. So the infrapatellar is the clergyman's knee underneath the patella from all the kneeling, and then prepatellar, so over the patella, is the housemaid's knee. Very politically incorrect. Good. All right. So 3 more questions. Going well. All right, before I lose you guys, let's go on. Good. All right, let's have a look at a picture. Good. All right, so just to make it hard, obviously the orientation and sequence of artery, vein and nerve is different everywhere you go. It would have been amazing if it was all the same every time. So for the popliteal fossa, the way I remember this one is serve and volley next ball. So if we go from medial to lateral, you start off with your semitendinosus muscles from the posterior compartment of the thigh, the popliteal artery, the popliteal vein, the tibial nerve, and then coming off on sort of like that 30-degree angle or whatever is the common perineal nerve or the common fibular nerve, remembering that perineal and fibula are the same, and then biceps femoris. And then also remembering, just make sure you know what a Baker's cyst is, and if you're doing a knee exam, comment on it when you're looking at the popliteal fossa. Okay. So this is probably the most important question, I think. And the other thing to remember is that the first thing you do with any sort of lower limb exam in an OSCE, always look at gait. Just never forget gait. If you remember one thing from today, just never forget to examine gait in a lower limb exam. All right, so I'll talk you guys through this one actually. All right, I'm going to talk you guys through this one and then see if you all got the right answer. All right, so if someone has foot drop, what problem do they have with their ankle? Is it plantar flexion or dorsiflexion? Dorsiflexion, good, because when they're walking along and they can't get their foot up, so they're always just sliding it along. So that's the first thing you've worked out. So that's very good. So you've already made a head start. So if there's an absence of dorsiflexion, you've gone back to your myotomes and you've thought, okay, dorsiflexion, myotome, that's L4, L5. And then if you've gone over your lower limb, if you remembered a little bit about your lower leg anatomy, you've remembered that the nerve that supplies the dorsiflexors is the anterior compartment of the lower leg, and that's the deep perineal nerve. Okay? So the other thing that it's got in the question is the first is the motor component. So you've got foot drop. The second thing you've got is numbness and tingling extending from the great toe up to the knee along the anterior leg. So if you had to put that in a dermatomal pattern, you're thinking, okay, that's maybe L4, L5, something like that. And if you had to put that into a cutaneous nerve distribution, you're thinking more superficial fibular nerve or superficial perineal nerve. So if we put those together, the answer's D. So let's... All right. Okay. All right. All right, so let's work through the answers now, okay? So why isn't it... So it's not sciatic nerve, because sciatic nerve is just... If you just remember, sciatic nerve is just that classic pain, so from the back, radiating down through the buttocks and through the back of the thigh. Deep perineal nerve, if it was just the deep perineal nerve affected, you'd think, okay, that explains the motor part of this question, but it doesn't explain why they'd be getting numbness and tingling, because the cutaneous, if you look here, the cutaneous distribution of the deep perineal nerve is this tiny bit between the first and second toes. Tibial nerve, the tibial nerve supplies the posterior compartment of the leg, so that's going to be performing plantar flexion, which isn't affected with foot drop. So the answer is L5 because that fits the motor component, which is the L4, L5 dorsiflexion, and also fits the anterior leg distribution. So just to summarize all that, the motor supply to the anterior compartment is the deep perineal nerve, and that performs dorsiflexion. The other branch, so we have the common perineal nerve here, which gives off the deep branch, which we've just discussed. The superficial branch is mainly a cutaneous nerve, so it's doing this large area here. and it also supplies a couple of muscles in the lateral compartment of the lower leg, peroneus longus and brevis, I think. Another couple of ways that this could present as a question is if someone's had a neck of fibula fracture, so that would affect the common peroneal nerve, and also if someone's had compression from a plaster after a fracture. So just remember a couple of presentations and foot drop. Really important. Okay, your last question. Good. Good. All right, so if we just look at this diagram quickly. Or maybe let's start with this one. Okay, so this is the tarsal tunnel, posterior to the medial malleolus. So the memory jog for this one, Tom, Dick, and very nervous Harry. So don't bother remembering what the muscles are. That's not important. What you need to remember are the nerve and the artery. Always remember what you need to remember is the nerve and the artery. That's basically the rule of anatomy now, from now on for you guys. So tibial nerve is the tarsal tunnel, and the posterior tibial artery, which you guys will come across if you're doing your diabetes exam or something like that. Remember, your two peripheral foot pulses are dorsalis pedis and posterior tibial. I just put in there for completeness, something anterior to the medial malleolus is the great saphenous vein. I think that's come up before, so I just wanted to put that in as well. So if we go back to here, if we look at the sensation of the sole of the foot, which can be kind of important. Muscles of the foot, not at all. Sensation of the foot, kind of important. So, tibial nerve, sole of the foot, here, the heel, the sural does the lateral side, saphenous does the medial side, and the superficial and the deep peroneal we've already discussed before. So the answer is the tibial nerve. Okay? That's everything I've got for you guys. As I said, it's not worth any more time. Anyone have any questions? Good. Just come and see me.